Okay, let's dive straight into something pretty specific today. Maybe you're hitting the books hard for exams or, just trying to get your head around conditions that aren't everyday common, but are really, really important to recognize when you see them.
Yeah.
We've got a set of detailed revision notes here on one particular condition, malignant otitis externa, and our mission really is to unpack them for you.
That's right. Think of this as us sort of guiding you through these notes, pulling out the absolute key nuggets of knowledge. The aim isn't just to read them back, definitely not. It's to talk through them section by section and extract what's genuinely high yield and memorable,
Yeah.
especially if you're revising for something like the MSRA.
Exactly. These notes cover malignant otitis externa in quite some detail, and it's one of those conditions you really can't afford to miss because, well, despite the name sounding a bit like just an ear infection,
Yeah.
it's much, much more serious than that.
Oh, absolutely. It is. It's a severe infection, and if you don't spot it, the consequences can be pretty significant. So maybe let's start right at the beginning with the core definition the notes provide. What actually is malignant otitis externa at its heart?
Okay, so the notes define it as a severe infection of the external ear canal. Straightforward enough. But then they immediately highlight the danger it's not confined there. It has this potential to spread to nearby tissues and even into the bones. This isn't your average swimmer's ear.
Precisely. That potential for spread is the critical bit. And the notes are very, very specific about who is most likely to get this condition.
Yeah, they put a huge emphasis on the demographics. It primarily affects elderly individuals, and here's the stat that really jumps out. 90% of cases, 90, occur in people with diabetes.
Mm-hmm. That 90% figure is just a massive clinical flag, isn't it? It fundamentally tells you this is often a condition seen in immunocompromised individuals. And uncontrolled diabetes is by far the most common reason for that immune compromise in this specific context.
Right, so think elderly, often diabetic. The infection starts in the ear canal but then spreads aggressively, causing, as the notes say, progressive inflammation and tissue destruction.
Yeah.
What's the usual suspect, microbe-wise? What organism are we usually talking about?
The notes clearly name Pseudomonas aeruginosa as the usual culprit.
Ah, Pseudomonas. Yeah, known for being a pretty tough bug to treat.
It is, yeah. And as the notes point out, the really serious endpoint, if this infection isn't brought under control, is progression to temporal bone osteomyelitis.
Osteomyelitis, so infection in the bone.
Exactly. It means the infection has actually reached and started damaging the bones surrounding the ear, the temporal bone.
Okay, so the key definition points are severe external ear infection, nasty potential to spread the bone, that's the temporal bone osteomyelitis part, typically seen in elderly diabetics. That 90% stat is key and usually caused by Pseudomonas. That feels like a solid foundation.
Definitely.
Now, building on that, let's look a bit closer at the etiology, the actual cause. The notes reiterate the main organism, but what else is worth noting here?
Yeah, they really hammer home that Pseudomonas aeruginosa is the primary cause. It starts as that infection in the ear canal, maybe just a tiny break in the skin allows it in, but its ability to invade, to spread into deeper tissues and bone. That's what defines malignant otitis externa.
Are there other possibilities mentioned? Or is it always Pseudomonas?
The notes do state that other bacteria and even fungi can occasionally be responsible, but really your default thinking, especially when you see a high-risk patient, should be Pseudomonas.
Got it. Pseudomonas front and center, which naturally leads us into thinking about risk factors.
Yeah.
So beyond that core demographic we've already hammered, elderly, diabetic, what specific factors do the notes highlight that make someone more susceptible?
Well, as you'd expect, they circle back really forcefully to poorly controlled diabetes, and the emphasis is on poorly controlled. It's not just having diabetes, it's about how well managed it is, because poor control really impairs the immune system.
Okay.
Advanced age is also a factor, makes sense. And just broadly, any state of weakened immunity puts a person at higher risk.
Right. Are there any local factors, things related to the ear itself?
Yes, good point. Chronic otitis externa. So someone who has long-standing inflammation or infection of their outer ear canal, that can be a starting point. And interestingly, the notes also mention swimming in contaminated water as a potential contributor, perhaps introducing the Pseudomonas or other bugs.
Huh, okay. So it's often a mix of that systemic vulnerability like the diabetes, age, general immunocompromise, plus maybe some local issues or exposures. That gives us a clearer picture of who needs really careful assessment.
Exactly.
Let's delve into the pathophysiology then. How does this destructive process actually happen? How does it unfold?
The notes describe the mechanism quite clearly. The infection kicks off in the ear canal, but the pathogens, particularly Pseudomonas, they have this nasty ability to extend directly into the surrounding soft tissues and then, crucially, into the temporal bone itself.
So it's like a direct invasion, not spreading through the blood necessarily?
It's primarily a direct extension, yes. These pathogens cause tissue necrosis, which is essentially tissue death, and they cause bone erosion. They're literally eating away at the local structures.
That sounds, yeah, quite horrific. How does the body try and respond to this invasion? Does it fight back at all?
Well, the notes mention the formation of granulation tissue in the ear canal. You might see this on examination. It looks like reddish, bumpy tissue. This is the body's attempt at healing and trying to wall off the infection. But in this kind of severe infection, it's often more a sign of ongoing aggressive inflammation rather than successful containment.
And how does the infection manage to get deeper? What are the pathways?
The notes indicate it spreads through the small blood vessels, the vasculature, and along the surrounding soft tissues. These provide pathways for the infection to move from the external canal right into the deeper parts of the skull base.
Okay, that spread mechanism explains why it can eventually reach the bone and start affecting nearby nerves and things. Now, thinking practically, if someone comes in with ear symptoms, there are obviously other conditions that might initially look similar. What does the differential diagnosis section of the notes suggest we consider?
Yeah, that's crucial, isn't it? You need to think broadly at first. The notes list things like cellulitis, which is more just a skin infection around the ear. Then there's cholesteatoma, which is that abnormal skin cyst that can grow in the middle ear. And also simple fungal otitis externa, a fungal infection, but typically not invasive in this aggressive way.
So how do you differentiate malignant otitis externa from those, especially given how serious it is?
This is where the notes really highlight the role of imaging. CT scans are mentioned as being crucial for assessing bone involvement. If that CT shows the infection has eroded into the bone, that's a very strong indicator of malignant otitis externa. It helps rule out those other conditions that are usually confined to soft tissue or the middle ear space in a different pattern.
Right, so imaging is really key for confirming the severity and ruling out those mimics. Moving on to epidemiology, the notes specifically mention the UK context. How common is this condition, actually?
Well, the notes state that the prevalence isn't perfectly documented, which probably suggests it's relatively rare overall.
Okay.
However, they immediately reiterate that it's more frequent in elderly individuals with diabetes, reinforcing that key demographic pattern we keep coming back to.
And looking ahead, any trends?
The notes anticipate that with an aging population and potentially rising rates of diabetes, the incidence might actually increase. So while maybe uncommon right now, it's something clinicians probably need to be increasingly aware of. The key takeaway from the notes here is, while rare, it will lead to serious consequences if it's left untreated.
Which brings us right back to why this deep dive is so important. Okay, let's focus now on what you actually see and hear from patient, the clinical presentation. What are the key signs and symptoms the notes emphasize?
Right. This is where your clinical suspicion really needs to kick in, connecting with those risk factors we discussed. The notes list severe unilateral ear pain as the hallmark symptom. Pain in just one ear, but really bad pain.
And importantly, what about how that pain behaves? Does it respond to simple stuff?
That's a critical point the notes stress. This pain is often resistant to standard antibiotics, like oral ones you might give for simple otitis externa, and resistant to simple painkillers too. So persistent worsening pain that just isn't getting better despite initial treatment, that's a major red flag.
What other physical signs or symptoms might be present? What else might you see or the patient report?
Foul-smelling discharge from the ear, purulent urea, is common. Hearing loss can occur, maybe if the canal is very swollen or if deeper structures are getting damaged, and you might see visible tissue swelling around the ear itself.
And is there a really concerning sign that suggests more advanced disease, something that really rings alarm bells?
Yes, facial nerve paralysis is mentioned specifically as a complication that indicates the infection has spread far enough to affect a cranial nerve, the facial nerve, controlling facial muscles. Seeing facial weakness alongside severe ear symptoms in a high-risk patient is extremely worrying.
Wow.
The notes also mention that patients might have systemic signs of infection, like a fever or just feeling generally unwell, although that's not always present.
Okay. The notes also included a neat summary of the key clinical features, which feels like the absolute Must-remember list for anyone revising this.
It really is. It's a great summary. It boils it down perfectly. Common in diabetics, that 90% again pops up, or other immunosuppressed individuals. Severe persistent otalgia, that's the ear pain. Temporal headaches make sense if the skull base is involved, right? Purulent otorrhea, that's the pus-like discharge. And then that potential for involvement of other nerves or structures, leading to things like difficulty swallowing, dysphagia, maybe hoarseness if the vagus nerve is involved, or that facial nerve dysfunction causing weakness.
That list is absolute gold for pattern recognition, isn't it? So you've got this high clinical suspicion based on the patient, elderly, diabetic, maybe, and their symptoms severe, resistant pain, discharge. What investigations do the notes say are necessary to nail this down?
Okay, first step is always a thorough clinical examination of the ear canal. You need to get a really good look in there. See if there's granulation tissue, check the extent of swelling.
And to find out what bug you're dealing with.
Microbiological culture swabs are essential. You absolutely need to try and identify the organism, especially to confirm if it is Pseudomonas, because that directly guides your antibiotic choice.
Makes sense. What about blood tests?
The notes recommend blood tests, yes. Primarily to check inflammatory markers like CRP or ESR to gauge the severity of the infection systemically. And, critically, to assess blood sugar levels, HbA1c, and current glucose, given that strong association with diabetes. You need to know how well controlled or not their diabetes is.
And then to confirm the extent of the spread, the damage.
This brings us back to imaging again. CT scans are specifically mentioned for assessing bone involvement and mapping out the overall spread of the infection. This often provides the definitive evidence you need for diagnosis.
Right, which leads nicely into diagnosis itself.
Yeah.
How is it typically confirmed, according to these notes?
The notes state that while the clinical picture of the patient, the symptoms, is highly suggestive, the diagnosis is typically confirmed with that CT scan showing the characteristic features, particularly the evidence of temporal bone involvement, that erosion.
Okay, so you suspect it clinically based on the story and exam. You do the bloods and swabs to support it and guide treatment, and you confirm it and see how bad it is with the CT. Got it. Now, management, how do you actually treat this very serious infection, especially thinking about the UK context, the notes reference?
Right. This definitely isn't a condition you manage alone in your GP practice or A&E in isolation. The notes strongly emphasize a multidisciplinary team approach. You absolutely need input from ENT specialists, ear, nose, and throat surgeons because it's fundamentally an ear condition. You need infectious disease specialists because it's a severe, difficult-to-treat infection. And you often need diabetic care specialists or endocrinologists because managing the underlying diabetes is absolutely crucial for treatment success.
A real team effort is essential then. What's the mainstay of the medical treatment itself?
Long-term intravenous antibiotics, that's the cornerstone. This is not a condition treated with a short course of oral pills. The notes specify using IV antibiotics that specifically target Pseudomonas infections, and they are needed for an extended period, often weeks, sometimes months, because the infection is deep-seated within the bone.
Wow, long-term HAVI. Does surgery ever play a role?
Yes, surgical debridement is mentioned as a potential intervention. This involves the ENT surgeons going in to surgically remove necrotic or dead tissue that the infection has caused. This helps clean out the infection source and allows the antibiotics to penetrate better into the remaining tissue.
And you mentioned managing the diabetes. Is that just important or is it critical?
Absolutely critical. The notes really stress the need to aggressively address underlying conditions, especially optimizing diabetes control. If the blood sugars remain high, the immune system remains impaired, and the treatment is much, much less likely to succeed. Recurrence is also a high risk if the diabetes isn't well managed.
Right. There's also a note about referral urgency in there.
Yes, the notes explicitly state that non-resolving cases, or patients whose pain is actually increasing despite some initial assessment or treatment, warrant urgent referral to ENT. This condition can deteriorate rapidly, so specialist input needs to happen quickly. Delay is dangerous.
Okay, so it's intensive treatment, involve the team, hit it hard with long-term IV antibiotics, specifically for Pseudomonas, consider surgery to clear dead tissue, and crucially, get that diabetes under tight control. What about the prognosis? If you catch it early and treat it properly like this.
The good news is the notes offer a generally favorable prognosis if there's early diagnosis and proper aggressive management. Timeliness and getting the treatment strategy right are absolutely key.
Okay, that's somewhat reassuring. But what if it's missed, or treatment isn't adequate or started too late?
This is where the notes are pretty stark. Untreated or inadequately controlled cases can lead to severe, potentially life-altering, or even life-threatening complications. This is why knowing about MOE is literally vital.
Let's just list those specific potential complications the notes spell out again, because they really reinforce why early intervention matters so much.
Yeah, it's a scary list. The notes include skull base osteomyelitis, meaning the bone infection spreads even further into the base of the skull, which is incredibly dangerous territory. Cranial nerve involvement, this can cause specific permanent deficits like facial nerve palsy leading to that facial droop, or permanent hearing loss if the auditory or vestibular nerves are damaged.
Really serious functional losses there.
Absolutely. And then, even more terrifyingly, things like meningitis infection of the lining of the brain and spinal cord, brain abscess, a collection of pus actually in the brain tissue,
Okay.
and septicemia, a widespread, life-threatening bloodstream infection.
Gosh. Those are incredibly serious outcomes. It really underscores the note's final strong statement about prognosis and complications, which they actually repeat, don't they?
They do, and it's worth repeating. Timely diagnosis and aggressive treatment are absolutely crucial to prevent these severe complications. That really is the main message you need to take away from all of this.
It is. So, okay, let's try and pull all of this together now, synthesizing it down. What are the absolute non-negotiable must-know points from these notes for someone revising this, or just wanting to be clinically sharp on MOE?
Right, the high-yield takeaway. The notes synthesize this perfectly, I think. You must think of malignant otitis externa in an elderly diabetic patient who presents with severe, persistent ear pain, often unilateral and purulent discharge. That specific combination in that specific patient group should immediately make this diagnosis jump into your head.
Okay. Elderly diabetic, severe resistant ear pain, discharge.
Yeah.
Got it. And the bug.
Pseudomonas. That's the key organism to suspect and target with treatment.
How do you confirm it? What's the key investigation?
It generally requires a CT scan to look for that characteristic bone involvement, that erosion.
And the treatment essentials.
Needs long-term IV antibiotics, specifically targeting Pseudomonas, and mandatory aggressive management of the underlying diabetes. Control the sugar.
In the bottom line, the reason it matters so much.
There's a very high risk of devastatingly serious complications if it's missed or not treated aggressively right from the start. Things like infection spreading to the skull base, permanent cranial nerve damage. Yeah, those points really do encapsulate the absolute must-know high-yield information from the notes. If you know those 5 things, you're miles ahead in being able to recognize and start managing this condition appropriately.
It really does. It connects the dots beautifully from the susceptible patient profile right through to the potential outcome if it's not managed well. It's a perfect example of why understanding the whole context, the patient population, the likely organism, is just as important as memorizing a list of symptoms.
Absolutely. It's all about having that high index of suspicion in the right clinical setting, in the right patient.
So here's maybe a concluding thought for you listening to mull over, stemming from these notes. Given that incredibly strong link to diabetes, that 90% figure, should we perhaps be thinking about screening for ear symptoms, or maybe incorporating targeted ear checks more routinely into diabetes management protocols, especially for older patients?
That's a provocative thought, isn't it? Thinking more proactively about identifying risk rather than just reacting when someone presents with advanced symptoms. It's an interesting angle.
Exactly. Applying these facts we've discussed to think about potential improvements in clinical practice is always worthwhile.
Indeed. Definitely food for thought.
Okay, well that wraps up our deep dive into malignant otitis externa, guided by these essential revision notes. We really hope breaking it down section by section like this, talking it through, makes the information clearer, more memorable, and genuinely useful for you, whether it's for exams or for your day-to-day practice.
Understanding these details can genuinely make a difference to patient outcomes. It's not just academic.
Absolutely. And if you are working through complex medical topics like this, especially if you're prepping for exams like the MSRA, please remember there are tons of resources out there to help you. Do check out passamsra.com and also freemsra.com. They have loads more materials, practice questions, all sorts of support to help you solidify your knowledge and feel confident.
Yeah, they're great resources for reinforcing these kinds of high-yield points and testing yourself.
Great. Well, thanks for joining us for this deep dive. Keep exploring these topics, keep connecting the dots, and we'll be back with another one soon.
Until next time.